Good evening, everybody. Welcome to the professional communication presentation that we're giving tonight as part of the RT Student Club meeting. Tonight is August 12th, and I apologize, I've got a duplicate date in there. It is only August 12th, 2020. I'll get that typo fixed there. But my name is Sean Matheson, and I help coordinate the RT Student Club. Glad to be with you here tonight. I see that nobody has yet joined. So I'll be watching the participant window. I'm joined here by my colleague, Daryl Goliford, Associate Dean, and he'll also be watching the participant window. So if any of you join as students, we'll see you and welcome you in. We are recording this, as you know, you're likely watching this on the recording. So we will post this both to the Facebook page, the RT Student Club group. We'll also post this on a YouTube channel that Professor Goliford has. So with that welcome, I'd like to turn the time over to actually Daryl, who's filling in for Dean Winka tonight with some announcements.
Okay, this is kind of a commercial for my own weekly event, which we're calling TMC Tuesdays. TMC Tuesdays, they take place at 6 p.m. Mountain Time. At my usual Zoom room location. We're trying to post that far and wide in the courses so students can find it. And also Professor Wilkinson is emailing it out to everyone. So what we're doing is taking topics specifically from the TMC exam. Right now we're working on evidence-based medicine. We're working on the GOLD criteria and the GINA criteria for evidence-based medicine of COPD and asthma. And we've got a great turnout. Last night, 12 students attended. I'd love to have 20 or 30 students attend. We do have someone joining.
Looks like Dean Wicca has joined us.
Excellent.
He'll be coming in on microphone here shortly. Looks like he's dialing in.
Okay, I'll complete that announcement. So join us. That's the point. Join us on Tuesday evenings, 6 p.m., and we're going to cover everything about the TMC exam that could possibly come up. We're going to explain how to get the questions right. We don't know the exact questions, no, but we know the topics that you need to study and the way you need to approach these questions to get them right. We're having success. We've had several people pass at the high cut recently, and I'm excited about that. I will share that I had a graduate pass at the score of 121 today, 121 out of 140. Wow. When I took the exam myself, I only scored 132. So this student did a remarkable job. So it's worth the time and effort. It's also fun. Join us on Tuesday evenings. And that's the end of my announcement.
Well, that is great. Thank you for doing that. And everybody, please do attend those TMC Tuesday. Just hugely helpful for you. It looks like Dean Wicca has joined us.
Yes.
Ken, is there announcements that you have for us?
I just want to welcome everyone that is attending or might be listening to the recording session. And thank you for being a part of our respiratory student club. In terms of announcements, we still not have heard any word for the entry-level BSRT program. That still is in the process. We have not put through the application yet. Our president, Dr. Hansen, said that if we could get, I think there's 13 more, correct me if I'm wrong, Daryl, there's, I think 13 more graduates from 2016.
I believe that's right, sir. Yes, sir.
If they could pass and get employed, then we would have met our benchmark for employment, which in the eyes of our accreditor, ACCSC, they might then favorably look at an application for a 4-year program. So we're working to that end. And so we want to get that 4-year BSRT program application put in so that we can have that. And we're doing our report of current status for our art respiratory accreditor, COARC. That's the Commission on Accreditation for Respiratory Care. We're probably not going to meet our threshold. We have to get 60%, 60 of our graduates from 2017, 18, and 19 to pass. at the high cut score. Right now, we have about 45%. So we got about 66 students or graduates that have to pass. We probably will not have that by the 1st of September. So by the time COARC looks at our report, which will be either November, December, we may be on probation for 3 years, roughly. That's what I'm thinking. And and folks, we need you to take this seriously. Unfortunately, we have a number of people that went through the program because things such, for instance, life gets in the way. Family illnesses, their own illness, work, financial problems, marital problems. But when you try to complete a program and then take the exam and pass at the high cut score, which is 92, you have to get 92 questions correct. It's, it's hard. And we do everything we can to try to get our graduates to take and pass the exam. So listen to what Professor Gulliford has to say. He's a wealth of knowledge and he's doing a fantastic job. So folks, that's all I have. I want to thank you for being here or for listening to the recording. And I wish you the very, very best. And, I wish I wish all of you to be safe and healthy and to do the best job you can while you're in the program. That's all I have to say. I think Dr. Mathis is with us. Is that correct?
Yes, Faye has joined us, Dr. Mathis as well.
She's our
Faye,
Associate
would you like
Program
to-
Director, right? And our Associate Dean of Curriculum. So I'm going to bail out because I have a dinner party I'm at. And we're going to let Faye say a few words.
All right, thank you, Ken. Take care.
Thank you, everybody. Have a great evening. Bye-bye.
Thank you, Ken. I too would like to echo what Dr. Wacka talked about. Our program is in desperate need for us to have all the successful graduates that we can possibly get. And I would like to also wish you all the luck and take advantage of all the study and the studyware and the reviews that that Dean Gulliford has put together. He's awesome, and he can see you through this. So you're not alone. Students do it every day, so it can be done. So good luck to you.
Well said. Good messages. Well, thank you, Dr. Mathis. I will advance forward here. So tonight we've put together some content. I call it translational content, meaning things that you can readily use in your practice as a respiratory therapist in daily operations. So we'd like to talk about professional communication tips that we have. And starting out here with really the center mostly of who we communicate with, aside from the patient, the physician. So when addressing, this may seem somewhat always understandable, but when addressing a physician, there are times you're going to run across where they say, just call me by my first name. I typically, and it's just a point of style, and I'll ask Dean Gulliford here in a moment, his style, and Faye, Dr. Mathis, please feel free to join in here at the end of the slide as well on your style. When a physician says to me, call me by my first name, I thank him or her for that, and I do so when we are in a personal setting. But when we are in a group setting, say we're among a team of our colleagues, I will still refer to the physician as doctor. It would appear, I think, out of step of me if I were to call that doctor by his or her first name if we were in a group. The second point here is be professional in your wording. I call this the prose of professionalism versus the vernacular of youth. So prose meaning the words we speak, the way we speak, vernacular meaning the phrases we choose. So certainly with a physician, you would not want to use the word dude or man or hey or any type of youthful vernacular. I think that with physicians, even in my personal relationships, and if I'm very close with the physician, I could be on the golf course with him or her, I would use a professional vernacular. in my address with the physician. Just a nice sign of respect. The thing I've learned working with physicians over the last 21 years, I need to be confident and yet respectful. And those two are not opposed. Those are not mutually exclusive. So being confident is knowing your data, knowing how the patient is presenting, having smart questions, saying so in a confident way. Being respectful, though, is deferring to the physician and asking her or his direction. So that's a third thought for you. And a fourth for my content that I've put together is to be succinct and specific. Nothing will kill a physician conversation quicker than being verbose or speaking too generally. So I like to have an ask at the end of if I'm giving, for example, a history of present illness or whatever the situation is, I have an ask at the end of it. Doctor, what's your thought on this? And before we move on to using medical shorthand, I'd like to pause here and just ask, Deans Goliford or Mathis, any thoughts that you have, additional tips on communicating with physicians?
I'll go first. The doctor is the doctor. There has to be a captain of the ship. Even if we have to tell the doctor something he doesn't want to hear, he's still the doctor. And in the clinical setting, they're all Dr. Jones, Dr. Whitson, Dr. Matuzik, to me. Of course, you get to know them personally, and it's different, as you said, in a personal setting, maybe on the golf course or maybe at a picnic or something like that. But in the hospital, it's doctor. And it's really, folks, all about their time. They're extremely busy people. They need to be productive. Many of them now are employed by the hospital or by clinics that actually have production standards that they're expected to meet. So we need to come to the point. We need to be organized when we talk to them, come to the point, and just get the answer we need, give them the information they need, and nothing more than that. That is all.
That sounds
Good points. Good points, Daryl. And I would also like to add, as far as being a professional, you always, as they both mentioned, you're going to be professional. And if you're like me, even when you see them in the grocery store, it is a hard train to get out of, to call them by their name. I mean, I run into physicians all the time in the grocery stores, and it's always doctor this or doctor that. They have such great respect for you. And another thing is, if you're professional, and as Daryl said, get to the point, and you treat them with respect. As respiratory therapists, there's going to be many times, especially if you work in small rural hospitals, that you are the therapist and you will sometimes be the doctor. So you have to make sure that you gain that doctor's respect and his confidence in you, so that you can call him up and say, look, I've got this patient that's come in and I really think we should try this. So the more you're professional and you gain that physician's respect, the more latitude that you will have to practice the skills that we're going to teach you to be a practicing respiratory therapist.
Well, thank you for that, Dean Gulliford and Dr. Mathis. That I hope is some good content for you, some good tips on how to best communicate with physicians. That last point there on the slide is really more to the written aspect of communicating with physicians using medical shorthand. I've provided a list here. It's funny, I use these just in all of my emails. You find it's just so much easier to write in these acronyms of shorthand than it is to type things out. And these add to that last point of being succinct and communicating in a quick, effective way. Any comments here, Dr. Mathis, or I guess we could start with you, and then Daryl?
No, I think they are pretty precise. And as you would say, you just always need to have good communication. And one of the problems that we have to make sure that we stay on top of approved abbreviations, and we want to make sure that we are not using something that is out of date, because that could potentially be a problem. So good reference here. Thank you.
Speaking of which, Dr. Mathis, if I were to write QD, would that be an approved shorthand, abbreviation?
I think it is. I mean, I hadn't been in practice and I hadn't talked in a while, but I think once a day or QD is, I mean, I could be wrong. You're making me feel like a student tonight. Is that,
Dr.
has it
Mathis,
changed?
it just recently happened, and let me explain what happened. Several times in different parts of the country, QD was mistaken for QID. They just looked too similar. Yes.
Okay.
So the patient received 4 of something that was intended for 1 of something. So that was, I think it was actually an American Medical Association action to request that hospitals remove that.
Okay. I can see how that could happen. So that recently just happened?
Just recently, yeah.
And you know, it's funny you said that because my LPNs were having that conversation the other day, and they too still think that that is a legal abbreviation. So that's not anymore. I'll be sure to tell them that.
Absolutely. Yep. It's just staying out of trouble. Avoid the trouble.
So is that is that universal? I mean, because could it be in different states that it's approved and not in all yet?
I'm sure there are differences, I'm sure, around the country. Yeah. Yeah.
Okay.
There is this Yale New Haven list. If you would Google and have students Google the Yale New Haven approved abbreviation list, a lot of hospitals are using it just because it's kind of standardized and it's very safe. They've taken out the things that cause trouble.
Right. And I can see how QD could be mistaken for QID.
Absolutely. Yep.
Yeah. Okay. Thank you, Sean. I needed that.
No, and that was not my intention, but it's a good illustration that you know, you can take somebody like Dr. Mathis that has her collective experience, and there are so many things every day that we learn, and I think that's the beauty of medicine is we all have that open mind to learning, and I've learned so much every day in my specialty of what I do. So stay on top of these. That's a great resource that Dean Gulliford has given us, the Yale New Haven list. And when communicating with physicians, always good to just use the common abbreviations, and this will create a nice, succinct feel and flow in your written communication. So moving on now to email communication tips. Again, a thought here of what I call the pros of professionalism. A quick story here. I have a cousin north of Seattle, and I had asked him if he knew of any physicians in a certain specialty in which I was working. And actually it was a kind of a sales program that I was working in. And he said, yes, I'll introduce you to Dr. So-and-so. Well, a day later, I got an email introducing me. And his email to this physician was, hey, doctor. No, I don't even think he used the word doctor. I think he just said, hey, Chuck, or whatever the gentleman's first name was. And I asked my cousin later about that. I said, how close of a relationship are you with this physician? He said, oh, we go to church together. And I didn't say anything. I didn't want to, correct my cousin, but I was thinking to myself, he's much younger than me, but it's just nothing that I would ever do. I would never say in a formal introduction, hey, Chuck, want to introduce you to my cousin. I would always say, hello, Dr. So-and-so, I'd like to introduce you to Sean Matheson. We're cousins. I would just use the pros of professionalism. And so be careful, no matter how familiar you are, they are, there's like Dean Gulliford said, there's got to be a captain of the ship. And we always want to use that professional vernacular, not the youthful. In our emails, the same. I'd like to show you an example here on a couple of next slides of being succinct using these same principles through the use of bullet points and headers. So on the left, and right, these are literally examples of emails from yesterday. On the right, I received this template of a letter, an email, that my documents team wanted me to send out, in this case to Dr. Cusick. He's in Champaign, Illinois. Well, I took the liberty and I can do this in my position, I reworded for what I thought would be a better approach to Dr. Cusick. So look at the right, that would have been 253 words. If you read there closely, the tone is somewhat passive. We suggest you, versus on the left, I'm using in that first bullet point, the word, will you please? It's just a tougher to digest email on the right. You'd really have to spend 3 or 4 minutes looking at that to at least 2 or 3 figure out what we're asking for. On the left, in contrast to what I did, I just said, hey, hi, Dr. Cusick, bad news. Here's the problem. To solve this problem, next paragraph, keep the problem and the solution separate, and then a bullet point and a sub, and a very specific ask, will you please? And then the sub bullet point of why I'm asking for that. Please text me or call me anytime. Thank you, Sean. 253 words versus 82, shorter, more succinct. The ask is there, it's specific. Dr. Cusick could be looking at this email on the left on his phone, which is probably what he does to get through most of his email, and he could then just quickly forward this to my ask. Here's another example, and I'll pause after this slide for the input of Dean Gulliford and Dr. Mathis. The longer email example. So this is an actual email that I wrote. This is about as long of an email as you will ever receive from me. And if I'm going to go this long, if I'm going to use this many words, I am going to give a numbered sub-bulleted list. And I'm going to give a header here of what it is that is in that section. So here I was talking about the billing on complexity versus time, and I gave a couple of points. Second point, the notion of specialists billing for chronic care management. Well, there are 4 different factors I think we should consider. And again, you just see those sub-bullet points. So, and I'm asking input here in the first sentence, which is harder to see up front, and then I'm asking at the end. I look forward to your thoughts. So if you go long, please consider the use of bullets, numbered lists, headers. You could even do a little bit of color coding. I rarely do that, but in this case I did. So I'd like to pause here. We could start with Dr. Gulliford. What tips do you have for written communication with physicians, and then also just in general within the organization?
I've got just one, and this is a tip I learned from the first CEO that I worked with. If it's that long, also copy it, put it on a Word document, and attach it so the doctor can say, print that for me and have it on my desk. It's a very simple step. Make it easy for them to print that thing so they can have it where they need it. Maybe it's going to hang on a bulletin board somewhere, or maybe it's going to be on the side of a computer, who knows, but make it easy for them. That's all.
Great tip, thank you. And Dr. Mathis?
And I would also like to add that if you got to send, or you need to send an email that is going to be, lengthy or something important, it will probably be a good idea to try to follow up with a conversation also, and sort of give them the gist of what it is that you're going to talk about. I found that works well for me, so that when I'm reading that email, I'll know where it's taking me. So, and one of the good things that I love about today's healthcare is that all of our charting and different things that we need to do are electronic. So it kind of eliminates a lot of the errors that can occur.
Very good point. Yeah, most
Excellent
of the communication
points.
is going to be within the electronic health record messaging platform. Very good point. Well, those are a couple of tips on written communication. So we'd like to zoom out here a little bit in the remaining minutes and give a high-level overview of what I think is the best book I would suggest is the best book I've read, get the correct verb, on communication, and that is Crucial Conversations. And you can see the authors here. I actually had a chance to listen to Mr. Switzer at a conference, give a summary of Crucial Conversations, and I found the book captivating, as well as their follow-up book, Crucial Confrontations. but conversations deals more with communication. So I'll just give I've got 3 slides here, I believe, and I'll give a very high-level overview of the concepts. I'll give you the Reader's Digest cliff notes here. So first, what you do happen.
I'm not hearing anything.
Oh, are you
Did it
hearing me?
break
Yeah.
up? Okay.
Oh, can you hear me?
I can now, but it was all robot-y.
Oh, okay.
So,
I'm glad I'm back. If you can hear me now, thank you.
yes, we can hear you now.
Okay, thank you. Seeking common ground, the second point here, waiting for what the to see happen in this situation. And it's a probing question. It puts the onus back on the person, and it really gets them to think. I think it takes to the conversation when you ask, what would you like to see from the conversation or from this outcome? Sharing to hear what you have to say and to respond. So you're both completely candid, but you're also very respectful. And I've noticed that physicians really appreciate the person. Words like to just even our personal prepositions that we use. It's just a whole demeanor of getting collaboration. So there's another book on this by Jack Welch. He was the CEO of GE. He completely turned General Electric around. Really a lot of the same concept here. Humility, we show our humility by asking others for their points of view and thoughts. Sticking to the facts, this works extremely well in medicine. Unless you're giving an assessment, you're simply conveying facts. And then soften the blow of the message. That's not trying to force communicating your thoughts in a very tactful way. Paraphrasing and acknowledging the narrative. This is a great technique, again, with coworkers and with patients. If I understand you correctly, your concern is, and you want to be careful when you do this not to overly simplify. You could offend the person if you did that. So paraphrasing, may I understand? Let me see if I understand correctly. I want to make sure I've got the details right. That's a great technique. And then lastly, de-escalating. So sticking to the issues at hand and not escalating your tone. I've heard it said that 80% of what we say is heard through the tone that we say it rather than what we say. People hear a tone and the emotional response is triggered in the other person more than what we were saying. So those are techniques from that book, which I have found extremely helpful. I'd like to pause there. Any thoughts with Daryl? Let's start with you, and then maybe Dr. Mathis on the communication techniques or any of those thoughts that were conveyed in the book.
Yeah, I have just one, and I think it's a pretty important one. Pick your battles. Doctors entered medicine thinking that they would be the decision makers about what goes on with their patients. They really had the audacity to think that they would be in charge of taking care of their patients. They entered a very different world, and it's changed a lot. So when they need to really do something different, let me just give you a quick example. I had a doctor who was using a particular diagnosis that was not getting the complete pulmonary function test paid for. It was just not. It was consistently losing. So that had to change. So of course we dealt with it. But if the doctor is doing something a little different than what we might have wanted because he believes it's important, let him do it. Pick the battle, you know. That's my only addition. Thank you.
Great insight, Daryl. Faye, what are your thoughts?
Well, you know, I learned a long time ago that the paraphrasing and making sure that you understand what someone says is very important. So I try to remember to do that, because a lot of times we hear the tone and we misinterpret what someone's trying to say. And I also agree with Daryl. You know, pick your battles. Do what the doctor says, unless it is going to be harmful to the patient. But if you learn how to communicate effectively with the doctor, or even the nurses, which are very important in our position to be friends with the nurses, because you just have to work together with them. You know, you can always suggest a different medication, or maybe suggest, instead of this patient getting these treatments 4 times a day, that they have improved, and maybe we can decrease them to 2 times a day. So it's all about your communication and your professionalism that will gain you that respect that you need.
Excellent points.
Now I do have a second point.
Perfect.
And Dr. Mathis triggered this. Sometimes a message may not be best coming from us. Sometimes the same message that comes from the practice manager, or maybe a partner in the practice. Recently, I used a nurse practitioner who just had a way of working with the doctor. You know, sometimes we tell them, here's the problem. Can you help me solve it? Absolutely.
That is a great point. I have often too found that if I go through the advanced practitioner, the NP or the PA, I can oftentimes get a quicker response and get things done effectively. The physician has so much work on his or her plate. I'd like to add just 2 quick points to the great points in this book and that Daryl and Faye have made. One is intention. I heard it said that 95% of the conversations we start end the way we, I'm messing this up. 95% of conversations end the way they started. And so if our intent going into starting that conversation is to be understood versus to understand, that's how we will come across, that one way or the other. So even if we're upset, if we can just say, hey, could you help me understand? And you say it in that nice soft tone, I have just found that works very effectively for me. The second thing I'd like to end with is, and really should be what we started with, and that is listening. For some reason, I keep going to 80%, but I would say probably 80% of communication is listening. And so if we find ourselves speaking over somebody, interrupting somebody, talking more than, say, 50% of the time with that person, wanting to get our next point in, those are probably signs that we're not listening. And I think people remember in communication more how they feel than what was said. So showing that empathy, that respect with patients, with doctors, it really goes a long way. So we'd like to conclude with a question here. And I see that we don't have any students joining. I know that this has been a very busy week. I know I live in Utah, and it is going back to school week. Daryl and I were visiting before this, the same in Oklahoma. I don't know your situation, Faye, in Georgia. I'm sure you're up against that here soon this week, if not next. So I'm sure many of you are busy and just weren't able to join tonight, but we're glad that you're watching this video. If you can join next month, it is always the second Wednesday at 6 p.m. Mountain. And there is a nice method of having a synchronous participation versus watching the video. in that we'd like to get feedback from you, questions such as this. We would like to nominate RT Student Club officers. And I actually have an appendix slide here on this. These positions can really look good on your resume if you were to serve as the president, vice president, secretary, board member. We'd like to get these meetings to the point where you are conducting a portion of it, even if it's just coordinating the agenda, opening us off and closing us out. We'd love it if you were driving some of the content. If you want to present different findings or questions that you have on things, and we could collaboratively discuss those. Any range of things. If we can get to that point here soon where we are nominating officers, it will be, I think, a good milestone for us in the evolution of our RT Student Club. I was just thinking, this is only probably our 4th, maybe 5th meeting. And Daryl made the good point. We've had COVID take place, still taking place. God willing, the vaccine comes out and we can, that will be effective. And we've had now, it's summertime. So hopefully here in the fall, we'll get some better participation. So please, we encourage your participation. Next time, we'd love to talk about the nomination of student club officers. We do have a couple of ideas here, soft skills, but very useful job interviewing skills, leadership skills. Daniel Williams, he could give us a presentation on professionalism in the clinical site rotation. And Daryl has a wealth, as does Dr. Mathis, of content and information to help you pass the TMC exam. And we can certainly bring those content pieces into play. Well, again, I'd just like to invite you to our next meeting. It will be the second Wednesday at 6 p.m. And so look for the invite. We do email those out a week in advance as well as a day in advance. And if you haven't, please go to Facebook, look for the RT Student Club, just do a search there and join that group. I'm the facilitator of the group. We are up to about 110 students. So we'd love to have you join. There is a lot of good collaboration there. You can ask fellow students questions and you'll see announcements from the university as well.
Sean, I'd just like to comment that 110 members of the Facebook page, which you created, says that students want to communicate in this way. So, I believe that we'll get more of them at the club, but if not, then at least they listen to the recording and learn something, and they've got the Facebook page that you created. Thank you. Thank you.
Yeah, that's a very good sizable number and like you said, very good means of communication for us. And feel free, text me, email me anytime you'd like. We're very happy. I'm happy to receive your communication. If you'd like, for example, to talk about the RT Student Club, about becoming an officer, we'd be very glad to have your input. Well, I will go ahead and hit the stop button. Let me check first here. Anything else from Daryl or Faye?
I'm good,
good,
thank
sir.
you. No, I'm good. Thank you so much for allowing me to share some of my insight tonight, Sean.
We really appreciate you joining, Faye. And
Thank
Daryl,
you very much for being here, Dr. Mathis. Thank you.
You're quite welcome, Dean Gulliford. I always enjoy hearing you talk about things.
Thank you. I've always got an opinion, that's for sure.
Well, we all do, that's for sure. Well, thank you everybody for watching this recording, and we will have this posted here. We'll put it on a YouTube channel, Dean Gulliford's channel, so that it will be there in perpetuity, and then we will post that link to the Facebook page. So thanks everybody, and have a safe and healthy August. Take care.